Hi, everybody. This is Alexa Tinsley, the Director of Community Engagement for JET Foundation. Thank you all for attending our webinar on non-surgical and surgical management of the tight foot and ankle. We are very excited to have Dr. Apkin and Carolyn Kelly here. We're going to start in just another minute or two. We're going to let people come on, but while everybody's logging on, if you could put your name, where you're from, and either your or your child's age in the chat, that would be wonderful. And we will be right back. Thank you.
I'm seeing an 11 and 19-year-olds.
Yes.
Sure.
8. And then also, just so you know, in the chat, make sure that you have it set to everyone instead of just hosts and panelists. That way everybody's able to see it, unless you want it just to go to the hosts and panelists. But if you want everyone to see it, make sure that it is set to everyone. All right, we will go ahead and get started. So again, I'm the Director of Community Engagement for JET Foundation. My name is Alexa Tinsley. Thank you all for being here and joining us. We're excited to continue our webinar series with the topic of non-surgical and surgical management of the tight foot and ankle. We are so happy that we're able to continue to provide accessible education to our community with these virtual webinars. We will have our first on-the-ground workshop in April 30th in Irvine, California. So this is an educational piece, but on the ground, but today is our virtual one. So if you have any questions about the on the ground workshop, please don't hesitate to reach out to me, alexa@jetfoundation.org. We are very grateful to Dr. Susan Apkin and Carolyn Kelly for helping us make this webinar possible and sharing their knowledge and expertise on the subject. I know it's something that I've heard about and something that is a much needed education topic in the community. So Dr. Apkin is the Fishis Chair in Pediatric Rehabilitation at Children's Hospital of Colorado, and she's also a visiting professor and vice chair of the Department of Physical Medicine and Rehabilitation at the University of Colorado School of Medicine. And then Carolyn Kelly is a physical therapist at Children's Hospital of Colorado, and her specialty is actually pediatric neuromuscular disorders, and she works in the neuromuscular clinics at Children's Hospital Colorado. She's also a clinical evaluator for neuromuscular trials, including therapy trials for SMA and DMD. So we're very excited to have them join us. And then I just want to mention a few things before we get going. If this is your first webinar series, we do offer these throughout the year. It is being recorded, so if you ever have to log off, you lose internet, or you just, you have to do something else, it will be recorded and available for viewing later down the line, and we will email that recording to you. This webinar today should be about 30 or 40 minutes, and after we'll be answering some questions. There is a question and answer box in your panel. So if you have any questions throughout the webinar, please feel free to drop them into the questions box and we'll make sure to answer them at the end. If you do want to chat, you are able to do so, like I said, through that chat feature, but all of our questions will be read through the Q&A portion. So that's all from me, and I will hand it over to Dr. Apkin and Carolyn.
So I'm going to start, and I appreciate everyone being here and taking the time, and we are hopeful that we can provide you with some good information so you can make informed decisions on behalf of your children and your family. So we're going to talk about non-surgical and surgical management of the tight foot and ankle. I will start by saying this is a really tough, the non-surgical management is tough. And so we appreciate all that parents do, and we know you're doing a very good job. At the same time, both Dr. Apkin and I do clinical research, and we know from other disease processes that when therapeutics become available, if your child has contractures interfere with abilities to get stronger, better, for the therapies to work. So this is a really important topic moving forward as more research and hopefully therapeutics become available for children with Duchenne. So we're going to start with what is a contracture. So a contracture is a fixed position of a joint. They occur at skeletal muscles. So you see here on the right, we have a picture of the gastroc. The pink reddish color is the actual muscle tissue. The white is the tendon, and then the tendon is attached to bone that crosses a joint that allows you to move. In children with Duchenne, skeletal muscle, this pink healthy tissue, is replaced by fat and fibrosis over time, which creates a more stiff muscle. And it then limits how much a joint can move. So common areas of contracture in children with Duchenne are ankles and heel cord, which is the topic of our talk today, knees, hips, elbows, and fingers. But we're going to talk about the foot. You're here to hear about the foot and ankle, so that's where we'll start. So first, we're gonna review the biomechanics of the tight foot and ankle. So why do kids walk on their toes? So it's actually starting more proximally. And so in kids with Duchenne, we see weakness in the knee extensors or the quads and the hip extensors. And so when you have weakness, it's hard to walk and you develop this sway back posture as a compensation. And then all of your center of mass is forward. And in order for kids not to fall on their noses, they rise up on their toes to keep balance. And so this is, I think, is an important feature because often I'll hear parents or people say in clinic, don't walk on your toes, don't walk on your toes, but they're walking on their toes for a reason, and it's to help them keep balanced. As the disease progresses and muscles get weaker, children also, or people will also start to walk with their feet further apart. And that creates tightness on the outside of the thighs, the iliotibial band pictured here. And when people go into a seated position, if they're not well supported in their wheelchair, that pulling of the tight thigh pulls the knees outward, and then you see the impact that has on the feet. So then the knees getting pulled out to the side and the feet start turning inward. And now not only do you have a pointed foot, but you have an inverted foot. So how do we measure range of motion? And it's important to measure because a lot of the recommendations we're going to be making today are based on what stage of the disease process your child is in, and also how severe is the contracture. So first, I'll draw your attention to the photo on the far right. Plantar flexion is the movement of the foot in a downward direction. Dorsiflexion is the movement of the foot in an upward position. We're going to call 0 degrees when the foot is horizontal to the ground. And dorsiflexion typically is between 10 and 20 degrees above that horizontal. In children with Duchenne, we typically say 0 to 10. But when the foot starts getting stuck in that downward position, there's not great, we don't typically use mild, moderate, and severe, although there is a group out of South Korea that describes mild, moderate, and severe based on how much range of motion you have. And I think that's important because it's, again, not so much what is the category, but where your child's range is moving. So on the far left, you see someone's ankle getting measured with the goniometer. And in the middle picture, they're using actually an iPhone to measure the range of motion in a standing position using an inclinometer. So there's different ways to measure depending on your therapist and your clinic, but it is good to have measurements about how much flexibility your child has in their ankle. So this, I think, is a good picture. So you see on the left and the right, what are the muscles that make up the heel cord? So you have the gastroc, which is red, which you can see is a 2-joint muscle, meaning that it crosses the knee and the ankle. So when you're stretching, your target is both knee straight and foot up. The soleus is a 1-joint muscle and only crosses the ankle. So most commonly we see kids walking on their toes as the compensation, but when you get tight heel cords, you can also have another compensation where you hyperextend your knees, turn your toes out and roll through the arches of your foot in order to get your heels on the ground. So just because your child can stand flat does not necessarily mean they don't have tight heel cords. So what is the impact of foot and ankle contractures on function? So we know that the dorsiflexion, the ability to lift the foot up, is one of the first body regions to demonstrate contracture in Duchenne. And it impacts walking and it impacts movement. And if not dealt with, it can lead to pain and skin problems. So in our clinic, we do time function tests, and this is a pretty commonly used tests at different centers, but the 4-stair climb, the 10-meter walk run, and the time to stand. And we know now that for every degree of ankle range of motion that is lost, we also see a concurrent 0.009 millimeters per second slowing down on the 10-meter walk. Now, I recognize that is a very small number, but still significant that if you are losing range of motion at your ankle, you are moving slower. The other test that is commonly utilized in muscle clinics is the North Star Ambulatory Assessment, which measures things like jumping, climbing stairs, ability to get off the floor. And again, we see if with ankle contractures, for every degree of ankle dorsiflexion that is lost, there is a decrease in performance of 0.23 points on the North Star. So the lower your score, the more involved you are. So this correlation, I think, is an important one. And then, of course, the things that are obvious, it's not comfortable to have contractures. It's harder to do transfers. It's just harder all around. So a group, including Dr. Apgon, put together a consensus statement based on available research to drive what is the best therapies, treatments, interventions for kids with Duchenne muscular dystrophy. So we're going to be utilizing and referencing this quite a bit today in our talk. This is sort of the cookbook of what to do when, although we need to also know the individual differences. But it is important because our suggestions and talk will focus on different stages of the disease. So ambulatory is when people can still walk. Early non-ambulatory is children who can stand and perhaps walk short distances, but are using a mobility aid like a wheelchair for longer distances. And then late non-ambulatory stage is for people who are primarily in wheelchairs. So let's talk about what do we do non-surgically. So number one is stretching. So stretching, as you all know, is moving a body part to the comfortable end range of motion. The hold is seconds to minutes, and you have to watch for compensation. So on this top picture, this is an example of an active stretch, meaning the person does their own stretching. But things like turning their foot out or rolling through the arch of their foot are common things people do to avoid the stretch at the target that you are really looking to go. In the bottom picture, you see passive dorsiflexion stretching. And this is typically utilized with younger kids or people who are weak and can't do their own stretching. And the recommendation based on the consensus statement is stretching should be done at every stage: ambulatory, early non-ambulatory, and late non-ambulatory. And it should be a comprehensive preventative home stretching program for structures known to be at risk, which we know heel cords are. There is not consensus about how long to stretch, but most studies say 30 to 60 second holds, repeating a couple of times, 4 to 6 times a week. So what does the evidence and research say that stretching does? Well, it's a bit inconclusive, unfortunately. We know stretching does not improve joint range of motion, and it is unclear the connection between stretching and function, meaning that once you stretch, you perform better. We know that if you have improved range of motion, you improve better, but not necessarily the direct correlation with stretching. Dosing parameters, and by dosing, I mean like how long you hold the stretches and how often you do it, they vary between studies, which makes it a bit difficult to compare different studies. So here's some examples of some of the literature. Stretching alone does not prevent contractures, and that was a program that did 5-minute sessions more than 3 times a week. And stretching does not change joint range of motion. It may temporarily decrease muscle stiffness due to decreased pain and more ability to tolerate torque. And that program was 30-minute sessions, 4 to 5 times a week. So we're going to tell you about what the consensus statements say. We're going to say what we're going to do some overviews of research, and then we're going to kind of boil it down to what our opinions are based on all of that, plus our own clinical experience. So I teach stretching to everyone. I think it is extremely helpful, especially when you have a situation where you have a child coming home from a long day walking at the zoo and they're crying because their muscles are cramping. Stretching is the go-to thing for me to help alleviate cramps. The idea potentially is that it improves blood flow to the muscle, which is helpful. but decreasing pain, even though we recognize it does not improve range of motion. Early education on heel cord stretching is important, and this is typically where we start. It is a short hold, seconds to minutes, but we pretty quickly switch to night splints if we note any changes in range of motion or function. And physical therapists or other different providers or physiatrists can measure your range of motion and help prioritize stretching and which joints, because to stretch everything takes a long time. And then here in this picture is a picture of a wedge, which is a way that we like to utilize active stretching, kind of an active passive stretch, because we think this is a great way for kids to do it on their own. They can multitask, read a book, game while they're standing on their stretching wedge. And we find pretty good tolerance with this. So moving up from most quick and least invasive to more invasive, then we move on to night splints. So these are some pictures with some night splints on the right. This is the DAF09 at the top and an over-the-counter Amazon variety on the bottom. And a night splint is a brace that you wear that has, you put the foot in a dorsiflex position, and it holds the foot in that position for hours. So instead of stretching, which is seconds to minutes, we're holding the elongated position for hours. These devices are not recommended for walking because, as we talked about before, weak muscles around your hips and your knees, the walking on the toes serves a function, and we don't want to change that. But when they're not walking, these static positioning devices can be helpful. The recommendation based on the consensus statement is start at a young age. This improves tolerance. Wear at night in the ambulatory and early non-ambulatory phases, and they can be worn during the late non-ambulatory as long as it is comfortable and you can customize it to the unique positions of the foot. Once the feet start turning in, these devices are typically not tolerated very well. And as you can see in this picture, this is what we're trying to avoid, but despite some best efforts, some feet just end up looking like this. But this picture on the lower right is an unbraceable foot. It is contracted to such a degree that no device that you're going to put on it is going to do much, and it will likely be painful. So the evidence for night splints are more effective than stretching alone in preventing contractures of the Achilles tendon. So when we think about night splints, we think maintain the range of motion you have. So the expected annual change in contractures was 23% less in the night splint group than in just the stretching group. And boys who wore night splints prior to losing walking walked longer than those who did not utilize night splints. Our clinical bottom line, night splints are better than stretching, likely just due to the total time that you wear them. We start recommending night splints early when we start seeing changes in function, slower times, loss of ankle range of motion. And our expectation with night splints is that you're going to maintain your range, but not fix the contractures that are already present. It can be used in non-ambulatory, like we talked about, as long as the fit is comfortable and the foot isn't turning in too much. And night splints should not interfere with sleep. So sleep is very important. If your child cannot sleep with a night splint on, we typically offer suggestions of wearing one night and one the next, or putting it on for after school hours when the child is doing homework or sitting and watching a show. Moving up in terms of more invasive intervention, so serial casting. So stretching doesn't do much, it feels good. Night splints maintain the range of motion. Serial casting improves range of motion, or at least that is the goal of it. So it uses a series of casts to stretch the soft tissue, and these are worn for a week. So instead of days, we're talking weeks. And the idea here is that you're actually improving range by changing the physical properties of the muscle, which is elongated. So you put the foot on stretch, you back off just a little so it can be comfortable. You cast the foot in that position. The person wears the cast, walks around in it for a week. They come back, they take it off, they measure, okay, do we improve our range? They also do time function tests and motor tests to make sure there's no loss of function. And then they go back and they make the stretch a little bit more, and then they cast again. So you're doing a series of casts in about one week increment, increasing range of motion incrementally. This serial casting is not formally recommended in the care guidelines, but our experience is early and strong late ambulatory phase kids who can still get off the floor without a chair. The average is 3 weeks of casting with weekly cast changes and motor testing in between. So boys with mild contracture, there was a study done, and that means less than -10 degrees with good function, meaning they were still strong, could get off the floor without using a chair. They improved their range of motion by 10 to 12 degrees short term. This isn't a long-term solution, it's temporary, without changes in function immediately following the period of immobilization. So that is was a big concern with serial casting, that if you immobilize and make put a child who is already weak in a cast, are they going to get even weaker after a week of being not able to move their feet and ankles? And according to this study, that was not the case. There is limited evidence to say that this serial casting improves walking. So clinical bottom line on serial casting, it improves ankle range of motion short term with stable function immediately following the period of immobilization. Younger boys have more rapid improvements than older boys. You need to closely monitor changes in function, pain, skin, and when you take off the casts. Discontinue if you're not making progress or losing function. And wedging under the heels allows for more comfortable walking so children can have a flat foot to stand on. So the best outcomes are in early to mid ambulatory phase with some gait deviations, mild to moderate heel cord tightness, and stronger kids do better. So I think just one comment on that is serial casting. This is an example of a person who has cast shoes on and is standing and walking. If your child goes into casts and they are not able to stand and walk as they did prior to the cast is not a good fit and it should be taken off. So this is not, they need to be able to walk around in them. Supported standing. Supported standing is a custom fit piece of equipment to help a person stand up for a prolonged period of time. There's a variety of options: sit to stand standers, supine standers, and wheelchairs that transition to standing. I've pictured here a standing wheelchair. The other ones we typically don't use because the transfers to get on and off of them, and they're big. And so the big piece of equipment in your house is often not worth it. But I wanted to make sure I mention them here. The recommendation is supported standing for late ambulatory to late non-ambulatory, as long as there is mild or no hip, knee, and ankle flexion contractures, because standing when you have multiple levels of contracture can be painful. Dosing is well documented. The recommendation is 5 days a week for 45 to 60 minutes in order to get the range of motion benefits. The evidence, so hips and knees got more stretched out and ankle plantar flexors did not, in a program that was 1.3 to 3.3 hours a week for 6 to 12 months. My suspicion is perhaps they didn't do it enough because that didn't follow that 45 minutes, didn't meet that threshold of the recommended. But again, it's important to know what is out there. We don't know what effect standing has on bone mineral density in people with Duchenne, and standing with poor muscles and joints and poor alignment is not good and can be dangerous to the joints. So for supported standing, careful selection and careful consideration is important. It's a big time commitment in order to get the benefit, and you don't want to be pushing through pain and contracted joints, which is typically why we suggest that they try standing with the standing feature before on somebody else's equipment or borrowed equipment before you start to think about ordering something for yourself. Ideal timing is late ambulatory phase in people without significant contractures, and it is challenging to get insurance to cover stand-up features on power wheelchairs. It can be done, but it is it is costly, and it's often you have to go through several several times with the insurance to get it covered. So you have to be pretty clear on one's comfort to do it and willingness to participate in a standing program. Treatments that we don't typically recommend, and we can talk further if people have questions on these or others, but dry needling, daytime AFOs, normalizing walking, and Botox are typically not recommended in children with Duchenne. And now Dr. Apgon is going to talk about the surgical options.
Thanks, Carolyn, and thanks for a fabulous review of the non-surgical options. And I point that out because when Alexa invited us to speak, the topic was really on surgical options. And I had to, we chatted a little bit because I wanted to make sure that the title of the talk really captured more of what we were going to talk about and more of what is regularly done in the setting of Duchenne muscular dystrophy, in that surgery is relatively infrequently used, and the non-surgical approaches that Carolyn just reviewed are actually very frequently recommended and used. So with that in mind, I will talk about some surgical options. And then again, as Carolyn suggested, we are very open to answering questions at the end. Like Carolyn, I'm going to talk about the early ambulatory, the late ambulatory, and then the non-ambulatory phases. And if people are interested in learning more about this, there are 3 articles that I would recommend that you refer to, and they're at the bottom and will be available after this presentation. But 2018, we had the opportunity to publish some care guidelines, and there was a rehab care guideline. There was a second guideline that included orthopedics, and then finally a specific article looking at the surgical recommendations in kids with Duchenne. So if you want more, please feel free to jot those references down. So when we think about kids with Duchenne who are in the early ambulatory phase, that means kids who are walking around primarily as the way they go from place to place, maybe in the community for long distances. They may be using a scooter or a wheelchair, or even for the little guys, an adaptive stroller, but primarily walking is their means of getting around. We do at times recommend a surgical intervention, and you'll hear us refer to it as a tendo Achilles lengthening or lengthening the Achilles tendon. And the general approach is when the contracture or the limitation in the joint is significant enough that the child is toe walking and it is impacting their balance and therefore safety, meaning they are so high on their toes because of contracture that they are falling more and they're at risk then for injuring themselves, including having a fracture. So that's the general tenet of surgery in the early ambulatory phase. While we think about the primary tendon that's involved, and with Carolyn's pictures, it was great to be able to see that Achilles tendon, the tendon that connects the calf muscles to the heel, is primarily that tendon that's lengthened because the kids are generally just up on their toes. At times, if someone evaluates a child who is going in for a surgical lengthening of the Achilles tendon, there may be a discussion about lengthening other tendons. We talk about the wide base, and so the hip abductors can be tight. The hamstrings or the muscles behind the knees can be tight, but in general, we do not recommend surgical interventions for any of those because of the underlying weakness pattern. Next slide, Carolyn.
Working on it. I did not. Oh, goodness. Oh, there we go.
Okay. So really important points. When you're considering a surgery, you're working with a team. And let me actually take a step back because I think this is a good opportunity to talk about how a decision is made. Oftentimes, the discussion initially happens with a family, the child, and a physical therapist. And that's a fabulous place to start. The physical therapist, he or she has their hands on the child, is measuring over time the restrictions in range of motion. So the conversation starts there. But really increasing the people around you to help make that decision. It will include an orthopedic surgeon because that's the person who does the actual surgery, a rehab physician like myself, or in your setting, it may be a neurologist. But the key consideration here before we'll recommend a surgical lengthening of the Achilles tendon is the child must have very strong knee extension and hip extension. So knee extension meaning their quadriceps are strong and they can get their leg out straight. Hip extension, or the gluteus maximus muscles, so those are the big bottom muscles, also have to be strong. We can measure strength on the exam table, but we can also measure strength indirectly through the use of some of the time function testing. Getting up off the ground and climbing 4 stairs is a measure of strength of those muscles. And so in our clinic setting, Carolyn will do those tests and bring back those test results, the times that the child has, and we're able to compare them to their results 6 months earlier. We also, through natural history studies, have a good sense of how a child's doing from an ambulation standpoint. For example, if it takes longer than 10 to 12 seconds to walk more than 10 meters, the child's at risk for losing ambulation over that year. That would not be a child we would consider in the early ambulatory phase, but in the late ambulatory phase, suggesting a lot more weakness. Therefore, we wouldn't recommend surgical intervention. The other thing to understand when a surgery is recommended is there are a lot of surgical approaches. And each surgeon may have his or her own or their preference in terms of what technique they like to do. There is not one clear best surgical recommendation. Next slide, Carolyn. I can show you here in this picture, here are examples of 6 different surgical approaches. And to the best of my knowledge, in the setting of Duchenne muscular dystrophy, there's not one single study that looks at a comparison between the results of one surgical approach versus another. These surgical approaches, or these surgeries in general, are typically done in children with cerebral palsy. And the difficulty children with cerebral palsy have is completely different than the setting of Duchenne muscular dystrophy. And so really being very thoughtful about the surgical intervention, the type of surgery that's recommended, and understanding that there's not one necessarily that's better than the other. Next slide. I'm going to give you just a few general surgical recommendations, and this is helpful in the setting of early ambulatory, late ambulatory, or non-ambulatory. My strongest recommendation is to do any surgical intervention, if recommended and agreed upon, in a setting where there are specialists in Duchenne muscular dystrophy. Not only do you need a surgeon that's a specialist and a therapist that's a specialist, but you need nurses and, frankly, most importantly, anesthesiologists. As you as parents know, there are some unique issues around having surgery and certain anesthesias in the setting of Duchenne that someone who's going to be putting your child under anesthesia needs to understand that. So while it's a relatively simple surgery, I mean, the surgery itself probably in some hands may take 15 or 20 minutes. That's the preoperative and the postoperative care that's so critical. So making sure you're in a center, and in my preference is a pediatric hospital with significant knowledge of Duchenne dystrophy. All children beforehand, if you go back, Carolyn. All children beforehand should have consultations with their pulmonologists, with their anesthesiologists, and their cardiologists, because we want to make sure, even for those who are in the early ambulatory phase, we understand their heart function, their lung function, and then anesthesia is going to review the risks around certain anesthesias. So making sure that that's part of your surgical considerations. And finally, as I said, you want the cardiologist to have experience and the anesthesiologist to have experience with Duchenne. You also obviously want the surgeon. Next slide. In terms of post-surgical care, it's going to be dependent on the surgeon. So every surgeon has a different approach that they may take. So for example, some might cast for 3 weeks, some could cast for 6 weeks. Some might say for the first few days, you can't be ambulatory. Others will be let you stand up and walk immediately as long as you're comfortable. So I don't want to give any specifics. You'll have to talk with your surgeon about that. You want to make sure that there's good pain control. Generally, this isn't thought to be an exquisitely painful procedure, but we want kids comfortable afterwards. So your child may be on narcotics and opioid for a day or two, and that's fine. Even in the setting of someone who is non-ambulatory, as long as they have good pulmonary support, generally they are very well tolerated. You want to initiate walking ASAP. Again, it's dependent on the surgeon, but we want to get those kids up walking. And so when you're talking to a surgeon, you want to make sure that they are going to be putting on casts that can be used with walking and standing. Generally, it's a regular cast, and then there's just a boot that's Velcroed on that has a tread so your child won't fall. Following the removal of the cast, again, it's usually at about 3 weeks, at least in our institution, you want to get your child into quickly physical therapy and then bracing. Now, Carolyn made a really important point. We don't typically recommend AFOs, braces, during the day for walking. In the setting of someone who has just had a surgery, it may be necessary short-term to protect the surgical site. And so we want to make sure that the child is safely able to walk in an AFO for a period of time. If they're not, then we may have to be creative and just protect the foot in different ways. And then after a surgical intervention for those kids who are ambulatory, we just expect them to be full-time in nighttime splinting as they tolerate, or at the very least after school while they're sitting getting nighttime splints. Because what you don't want to happen is that they've had this surgical procedure and then they lose range of motion in the future. Next slide. Complications of surgery, whether you're in the early ambulatory or late ambulatory, pain is a complication. We would expect it. Again, relatively well managed with something like acetaminophen or ibuprofen. Opioids sometimes for a couple of days are necessary. There is a complication of chronic nerve pain. It's unusual, but when it happens, it can be uncomfortable. And nerve pain is the pins and needles, the burning pain you get when you hit your elbow. And we talk about the hitting your funny bone. It's that nerve irritation. I happened to be in clinic, an adult clinic, and chatting with a 34-year-old the other day, and I was mentioning to him that I was going to be doing this presentation. And actually his mom reminded him of how much pain he had after his surgery, and it was that nerve pain. And so it's something you should be aware of. It can be treated, but when it's happening, it's quite uncomfortable. Risk of infection, while it's low, it's there. It's just a surgical site infection. The surgeon will go over that. For a child who's in a cast, you can have a pressure sore underneath the cast. So a child who isn't necessarily able to tell you exactly what's uncomfortable when the cast is removed. Sometimes you'll see that there's a sore underneath that. And then finally, and I started this is for the kids in the early ambulatory phase, is that there is a risk of loss of ambulation. That is why the team approach is so important. We never want to see this as a complication of surgery, right? This is an elective procedure. We want to make sure that the child who is recommended for a tendo Achilles lengthening is someone who is strong. Their hip extension, their knee extension is strong. Their time function testing are robust. We want to make sure that that loss of ambulation is really minimized to the largest degree possible. Next slide. Now, late non-ambulatory phase, I'm going to say it pretty easily. We don't recommend tendo Achilles lengthenings. Those are kids who are weak in quadriceps, weak in hip extension, and they are at high risk to lose ambulation. So again, relying on the time function testing and the strength testing by your physiotherapists, rehab physicians, or neurologists is going to be very helpful. I really encourage the entire team to make the decision. Having an orthopedic surgeon in isolation make the decision about a surgical lengthening is not the best care for your child. Next slide. So in the early or late non-ambulatory phase, I think that we really want to have the kids driving those recommendations as much as the rest of the team. Some of the goals for a surgical correction in that non-ambulatory phase. In the late non-ambulatory, this picture, similar to the one you saw with Carolyn, the feet are not only plantar flex, or the toes in the down position, but we use the term inverted. Those feet are really almost pointing, the bottoms of the feet are almost pointing towards each other. And so that can be uncomfortable, can lead to some skin issues on the foot rests. It's difficult to wear shoes when your feet have such significant contractures. And for some kids, that's an important point. We want to make sure that they're part of that decision, and that ties into cosmesis, or the look of the feet. In the early non-ambulatory phase, Some boys or kids with Duchenne are transferring with some assistance. So having flat feet can assist with those transfers. And so that might be an important goal to reach for. In the late non-ambulatory, when there are some cardiac or pulmonary involvement, we want to make sure that you're balancing the goals of cosmesis or shoe wear with the risk of pulmonary or cardiac decompensation. That's a big deal. And again, having your cardiologist and pulmonologist involved is going to be important. Next slide. So in surgical options, I talked about in the early non-ambulatory, generally the foot is just in the down position. The lengthening of the Achilles tendon is really the only surgical intervention that's necessary. If you think back to the picture you just saw, the foot not only down, but it rotated in. Oftentimes there are other surgical approaches that are necessary. So the surgery, the simple surgery, the 15-minute surgery I talked about for the early non-ambulatory may be much more extensive in the non-ambulatory. Additionally, and this is the time when someone's become wheelchair dependent, they're not walking anymore, we see more contracture with knees and hips. In general, however, we don't recommend surgical intervention. And when I say we, it really is the care guidelines. So these were a group of specialists across the country and internationally that looked to the literature, research studies, and then consensus when there wasn't research to review. And the risk of having neuropathic or that nerve pain is higher, especially when you operate on the knee, and the benefit doesn't outweigh any risk. And so in general, it's not recommended. The surgical approaches, as I said, are going to be more extensive or may be more extensive. They're dictated typically by the goals of the child and family, as well as the foot position. The Achilles tendon I talked about. The toe flexors may be very contracted as well. And so there may be a recommendation to operate and lengthen those the tendons of the toe flexors. The posterior tibialis muscle is that muscle that pulls that foot into the in position. And at times, a lengthening or even a transfer of that tendon is recommended. So a lengthening, again, I talked about the different approaches, is just to give you more length so you can swing that foot back into a good position. A transfer is actually when you take the tendon and you split it in two and you put one part of the tendon on one side of the foot with the other tendon on the other side of the foot. And it's more of a balancing procedure. And that can be effective when the foot is very inverted or supinated. Next slide. The post-surgical care in the non-ambulatory child, again, assuring good pain control. A couple of days of opioids is oftentimes recommended. It's safe. Daytime AFOs, from my standpoint, as soon as the casts are removed in the non-ambulatory patient, I would put AFOs on and continue to wear them long-term. And that's something that I set as an expectation with the young people who are having this surgery, because I want to make sure that they understand that the surgery is not just one and done. It is one-time surgery and then long-term maintenance. Now, I will say, the young man who had that surgery that I met with last week, he hasn't worn IFOs in a very long time, and his feet have maintained because he spends the majority of his day in his wheelchair, and his feet then are in a really nice position. So I set that expectation so that no one's surprised, and if it's not necessary, fantastic, we can remove that recommendation if not needed. Next slide. Actually, with that last slide, I am going to end and thank, actually, Alexa, thank you and the Jet Foundation for inviting us. Again, while you originally asked us to talk about the surgical approaches, I hope that those of you listening will appreciate that while surgery is something that's recommended, the non-surgical approach is really what's key to the success at maintaining the range longer term. So with that, I think, Carolyn, you and I are happy to answer any questions. And Carolyn, I would love to hear, actually, if you have any comments. I had jumped over some of the post-surgical approaches. Do you have any recommendations additionally to what I had said?
No, I would just reiterate your points of, I think a lot of times people think they're going to get the surgery and then they don't have to worry about the feet anymore. And yes, the surgery is great in terms of making the correction, but especially if the child is still growing, depending on their walking status, how well their equipment fits. It may not be a lifetime fix. Some children it is. And I know most of the people that I know that have had the surgery are happy with the outcomes, but it is between the pain and the rehab afterwards. It's a lot. It takes some work to get back to where you were prior to surgery.
Thank you guys so much. If you guys have any questions, please put them in that Q&A panel. And like Dr. Apkin and Carolyn said, they're happy to answer any questions. I know that sometimes, you're sitting on a question and you can't really put it into words right now and so quickly. So if you do have any after this webinar, please feel free to reach out to me and I will get them to Dr. Apkin and Carolyn, and they will provide answers as quickly as they can. I'll leave a minute to see if any questions come in. But I do, again, just want to say thank you, Dr. Apkin and Carolyn, for this presentation. I know I originally did approach you about surgical, but I really think that just providing education and allowing our families to make informed decisions is truly so important. And I think that that's exactly what you went over today. So thank you guys very much. All right, so I don't see any questions. I do see in the chat that people think it's great information and it was very helpful. So thank you both so much. Again, if anybody has any questions, please email me at alexa@jetfoundation.org and I'll be happy to get them to Dr. Apkin and Carolyn. We thank you so much for being here. We hope to see you again at our other webinars throughout the year. If you have any suggestions for any other educational topics that you'd like to see, please feel free to reach out today. We hope you have a wonderful day. Oh, we do have a question. My son, who's 22 years old and has been in a wheelchair since he is 11, he is up for surgery. Is that something that you would recommend?
I think I'd ask a few more questions. So if your son is up for a surgery, what is it that his goals are? And what does he want to accomplish, or what do you want him to accomplish with that surgery? The other thing I think about when I'm having a conversation with young men, especially, is I want to know their physical exam. So, how tight or how loose are the feet? Is it something that we can just brace and avoid a surgery? Is it something we can do with the wheelchair, leg rests? I also want to know a little bit more about the medical issues. So, 22-year-olds these days may be on some BiPAP, but otherwise doing really well, may or may not have any heart involvement, but that again is going to play into that role. So right now, the goals are the big thing for me. What is it that he's hoping to accomplish? I'll just sort of add, if the goal is for feet to be flat on the footrest for better sitting balance, if your feet are really turned in, super hard to sit, shoe wear is a big deal. I live in Colorado. It's cold here, and 22-year-olds want to have, cool shoes. And so that for me is actually a valid goal, and one that, I think that, would consider, again, as long as someone's heart and lung function are good, and pulmonary and cardiology sign off, I'm supportive. Carolyn, how do you think about it?
There is a clarification. It is for either Botox or to cut his Achilles tendon.
So Botox is not appropriate to use in the setting of Duchenne muscular dystrophy. And a full stop in my mind. I actually, in my other day job, I do take care of kids with cerebral palsy. They have the opposite problem. They have tight muscles. They have spasticity. Botulinum toxin is indicated in the setting of spasticity, and that's the driver of the tight Achilles tendon. Boys and men and kids with Duchenne dystrophy do not have spasticity. The muscle, as Carolyn mentioned earlier, is not normal muscle. There's fibrosis. It's kind of the gristle of that you see on like a muscle of that you're eating of chicken or beef. It's fat that's in there, and so that is not really, Botox is not really indicated. But it's actually something, I'm glad whoever brought it up, because it's something that we get asked a lot by therapists who don't take care of kids with Duchenne. And so then we have to provide some education. So thanks for asking that question.
And we do have another one. My son, 17, is in the late ambulatory stage, but does ambulate with a rollator in the home. One foot is starting to turn and we are using a wheelchair mostly now. Wondering if doing 1 foot would help him to maintain some ambulation.
Carolyn, you want to take that one on?
Sure. So I think that if the reason why, again, it's needs some further clarification. So if you believe that the reason why he's going to stop walking is because it's turning in and it's running into the other foot and causing him to trip and fall, then that makes sense to me. But at the age of 17, my suspicion is the muscles are just so weak around his hips and knees that would, that's probably why his foot is starting to turn in. Again, without seeing him and assessing him, that's hard to know. But if he's close to losing walking, Dr. Epcon had mentioned that in her talk, when kids are close to losing walking, one little thing like, and surgery is not a little thing, but something like a surgery, something like a fall or a fracture, that can take them off their feet because their walking is so precarious to start out with. It's unbalanced, it's hard. And so something like a surgery and even a 3 to 6 month period of being casted and immobilized can really change someone's function at that critical window.
Perfect, thank you. And then if you guys have any other comments or that you'd just like to finish up with, because I know you were about to say that before I asked the question. So if you had anything else.
I would just like to say, I mean, I think that this, having a physical therapist and a rehab physician like myself presenting this, I think is a neat opportunity, hopefully, for folks to hear how we work together and think about it. I would never make a decision in isolation without Carolyn's input. And then obviously the input of the child or young person and family is critically important as well. That surgery is really is something we certainly will recommend in the right setting, but the non-surgical approaches that Carolyn mentioned are just so important. And so I appreciate having the opportunity through Jet Foundation to be able to talk about this.
Perfect. One more question came in. My son is non-ambulatory and had surgery 2 months ago. He is using AFOs at night. Is it necessary to use them in the morning too?
So I think it depends on what your orthopedic surgeon is recommending. So again, that person can collaborate with your muscle team, but depending on what surgery is done, there's guidelines to follow. If he just did muscles or if he just did bones, the different post-operative procedures is definitely an orthopedic surgeon question. So
I also think about, if the wheelchair is fitting really well and the feet are really well positioned on the footrest in a really flat way. Some kids like to bring their legs off the footrest and then the toes are hanging down. That's probably someone who would benefit from AFOs. But if the feet are really well positioned on the footrest, once the orthopedic surgeon gives her sort of approval to stop wearing braces altogether, then I think practically, if the foot is well positioned on the footrest and the child's not hanging their feet over, then the AFOs during the day may not be as necessary, which is great, especially if they're tolerating them at night for a good stretch.
Perfect. And like someone just said in the chat, this was so valuable. I am going to close the Q&A, but if anybody does have any other questions, please feel free to reach out to me. Like I said, have a wonderful day and we hope to see you soon. Thank you again, Dr. Apkin and Carolyn. We really appreciate it.
Yeah, take care. Thanks.
Have a
thanks
great
for
day.
having us.